Hello, my name is Dr. Masuda. I'm a second-year psychiatry resident here at Creighton, and today I'll be talking about a case report involving a patient who had overdosed on fluoxetine and bupropion and developed serotonin syndrome. So here's my abstract. We'll talk about serotonin syndrome for a little bit, and then we'll discuss the case, and at the end we'll look at some literature that involves serotonin syndrome and bupropion's involvement. So here's my introduction. So serotonin syndrome is a systemic consequence of inappropriately high levels of serotonin in the body. It's commonly an adverse effect of pharmacologic misuse. There's a little evidence that the atypical antidepressant bupropion, whose mechanism of action is through the norepinephrine and dopamine pathways, can precipitate serotonin syndrome. And we should be aware that in some cases, yes, bupropion can precipitate the condition, and the reason why it's so important is that in severe cases, the condition can be fatal. So here's my case presentation. We have a 25-year-old Hispanic woman with a past medical history of lichen sclerosis and PCOS, and no known past psychiatric history because she presented to the ED around midnight due to a drug overdose. When she arrived, she was able to talk, she was alert, and she had informed the emergency room staff that she ingested 27 tabs of fluoxetine, 20 milligrams, and the same number of tabs of bupropion, ER 150 milligrams, as a suicide attempt. In addition, she had reported drinking alcohol that evening. On physical exam in the ED, she appeared with warm and dry skin. She was hyperreflexic, alert but drowsy, and with slurred speech. Medical workup revealed a leukocytosis, a negative UDS, elevated alcohol level, and a prolonged QTC. She was given activated charcoal, lorazepam, and magnesium, and eventually admitted to the medical ICU because she became very agitated. She was a high risk for falls, and also for her safety. She was pulling lines, and so she needed the escalation in treatment. She also experienced a seizure and was given lorazepam. Toxicology and psychiatry were consulted as well, and so when we saw her in the morning, she was awake but neither alert nor oriented, and she was unresponsive to our attempts to engage her in conversation. Her vitals revealed tachycardia and tachypnea, and physical exam showed that she was still in soft restraints, and she had these rhythmic jerks that were more prominent in her lower extremities bilaterally than her upper extremities. And the MSE was very limited because we weren't able to have like an interview with her. So we dug through the charts and we couldn't find any records from her at other facilities. And we called family members. Her brother said that the patient has had previous suicidal ideations in the past due to antidepressants, but he was unaware of any manic, depressive, or psychotic symptoms otherwise. She did have suicidal thoughts about 1 week ago, and the brother said the patient had started work at a local hospital, began graduate school a couple months ago, and used substances like alcohol and THC. The brother did mention that the patient saw an outpatient psychiatrist, but was very unsure who or where this was, and we were unable to obtain records. So the diagnoses that we gave her at the time were medication-induced delirium, acute with a mixed level of activity, suicide attempt, alcohol intoxication, and also serotonin syndrome. So what is serotonin syndrome? Well, it's a mild to potentially life-threatening condition caused by serotonin toxicity, typically develops within minutes to hours after serotonergic medication use, drug interaction, or overdose. In other words, it's due to serotonin toxicity. And as a syndrome, it has 3 characteristic features that we can see here: mental status changes, autonomic instability, and neuromuscular hyperactivity. We can actually diagnose serotonin syndrome using the Hunter serotonin toxicity criteria, which I have listed out here on the slide. So if you're on a serotonergic agent, you go to the right side of this picture, and if you have any of these symptoms, clonus, agitation, diaphoresis, tremors, in combination, then you have serotonin syndrome. And this condition does have different levels of severity. On the left, we can see how the neuromuscular, autonomic, and mental status symptoms present when it's a common drug side effect at mild levels of serotonin syndrome and ultimately severe levels as well. And then the illustration on the right kind of shows what you would, like a patient, if you were to see them in person and see like how their behaviors are. We can see that they're confused, they're diaphoretic, they have myoclonus, and there's lots of agitation. And that brings us to our next slide, a discussion of the literature. So on the left, we have a case report of an elderly patient who had developed serotonin syndrome after taking bupropion and sertraline. And the authors posited that bupropion's inhibition of cytochrome P450-2D6 actually led to increased levels of sertraline as the hepatic metabolism was slowed down. The middle study was actually a retrospective study from a toxicology center where they looked at patients who had overdosed on bupropion, and of like 90 patients who had bupropion overdoses, they narrowed it down to 18 patients who had overdosed purely on bupropion and no other agents. And of those 18, 6 or 33% had developed serotonin syndrome. And the authors posited here that at high levels of bupropion ingestion, bupropion has serotonergic activity. And the median dose in that group was about 2,250 milligrams. And on the right are just two case reports of serotonin syndrome developing from bupropion use alone. The first involved a child who had overdosed on about 2,250 milligrams, so the same amount, and developed symptoms. And the second case details a patient who had ingested approximately 8,000 milligrams of bupropion, so quite a lot, and she developed serotonin syndrome. So although rare, it does happen. So how do you treat serotonin syndrome? Well, you'll stop the serotonergic agent first, and most of the treatment is supportive. You want to stabilize their vitals, make sure the breathing, the cardiac status is fine. You want to observe them as well. And for severe cases, they may require ICU interventions similar to our patient. Now there are pharmacological agents, benzodiazepines and serotonin antagonists such as cyproheptadine can be used. There are also other miscellaneous agents like sympathomimetics, cardiovascular agents, vecuronium, and it's important to avoid medications like antipyretics, propranolol, and so forth. So getting back to the patient, she had received supportive care in Aziad, lorazepam. She was medically stabilized, her CK downtrended, and there was no seizure activity found on EEG. By day 3, she was more alert and was able to tell us that she was undergoing lots of stressors, including coming down with the COVID infection, engaging in graduate school, and also working simultaneously. She did report a history of MDD, ADHD, unspecified anxiety, and panic attacks, and was prescribed fluoxetine and Abilify, but that combination made her sedated, and so her PCP switched out Abilify for bupropion. Interestingly, she came from a very hyper-religious family with a mother who believed in demons and spirits, and so the patient always grew up to believe that she was being haunted and followed by ghosts and spirits everywhere she went, and this kind of precipitated some of those history of psychosis, including the auditory and visual hallucinations. Ultimately, the patient made a pretty good recovery and went to a local voluntary inpatient psychiatric unit for further stabilization. So I apologize for running a little over, but thank you for taking the time to listen to my case report on a patient who had developed serotonin syndrome after bupropion and fluoxetine overdose. I'm looking forward to meeting all of you for the question and answer session this Thursday. Thanks. Oh, and here are my references. Thank you.